afternoon, everyone. Thank you for joining us for today's Grand Rounds. It is my great pleasure to introduce Dr. Cassandra Cassie Bonus, who is a research assistant professor at UNM's CASA. Cassie completed her PhD in clinical psychology at the University of Missouri and completed her clinical internship at the University of Pittsburgh Medical Center. Dr. Bonus conducts mixed methods research on the etiology, assessment, and treatment of substance use disorders, and is currently funded by a National Institute on Alcohol Abuse and Alcoholism Career Development Award. Dr. Bonus is particularly interested in developing and refining assessments of substance use disorder etiological mechanisms with the eventual goal of facilitating mechanism-based precision medicine. Clinically, she specializes in motivational interviewing and has a strong background working with the deaf and hard of hearing communities in American Sign Language. Dr. Bonus also has expertise in professional ethics, especially as it relates to emotional support animal evaluations. And in fact, you may remember that Dr. Bonus, even before she was Dr. Bonus, was here and presented with Dr. Youngren on that topic. Gosh, was that pre-COVID even? It was, because we
2019, yeah.
Okay. And she has a strong record of publications in that area as well. So without further delay, please welcome Dr. Cassie Bonus. Thanks.
Thank you for the introduction. Let me see if I can just share my screen here. Okay, are you seeing my slide or the presenter view? Good, okay. All right, let me move this so I can see some of you. It's always nice to see some faces. Thank you for the introduction. I'm Cassie Bonus. I am relatively new to the University of New Mexico. I just have been here a little bit over a year. I did present in Grand Rounds back in February, so you might have heard me talk then as well. If not, I'm thrilled to be here. It's nice to meet some of my colleagues across Lomas. So I'm going to be talking about some of my more recent work related to evidence-based assessment of substance use disorder that was conducted alongside some of my colleagues, both here at UNM, JC Gonzalez, who is a current HSC clinical psychology intern, Kamala Venner and Katie Wickowitz, who are also in the Department of Psychology and at CASA as well. And then my colleague, Dr. Chelsea Sleep, who is at the Cincinnati VA. So one of the questions that I love to talk about is, what is evidence-based assessment and why does it matter? And particularly, why does it matter for substance use disorders? So if you haven't heard this kind of phrase, evidence-based assessment, before, it is kind of a formal term that has had several books and papers published on it. And what that really is intended to convey is kind of this integrated approach to assessment that uses research and theory to inform the selection of assessment targets, the methods and measures that you might use to assess those targets, and then the specific assessment processes, are kind of the act of assessment itself. One of my kind of ongoing pet peeves and mistakes that I see in the literature often is that people kind of conflate the phrase evidence-based assessment with psychometrics. Describing evidence-based assessment as kind of the selection of psychometrically sound or valid or reliable assessment instruments, but really evidence-based assessment is much more than just that. And instead, what evidence-based assessment really aims to do is to recognize kind of the inherent complexity that is involved in a clinical assessment, and recognize that this is really kind of an iterative decision-making process that we go through as assessors or as clinicians, or kind of in whatever role you might be as a researcher, for example. So the guidance on evidence-based assessment really highlights the importance of integrating information across data sources with the goal of kind of achieving the best clinical outcomes for a given person or a group of people. So the presentation that I'll give today is based on an invited manuscript that's currently under review right now, and I'll tell you how to access that at the end. But what they asked me to do was provide up-to-date information on evidence-based assessment for substance use disorder. And sadly, this is kind of a diagnostic category or group of people that are often overlooked in discussions about evidence-based assessment. And when you look at some of these kind of special issues that exist out in the literature, oftentimes substance use disorder is not included in that. So I know my colleagues and I are really, really grateful to have been invited to contribute to this, and we hope that it's useful. So I'll go over quite a few things today. I know we don't have a ton of time, so like I said, I'll show you how to access the paper if you want more information. But what I'm hoping to do is to describe the updated evidence on how to select the best treatment targets, how you can choose the methods or measures to assess those targets of interest, and then talk a little bit more about the specific procedures or considerations that assessors or researchers should follow in order to kind of integrate all of this information and consider the whole person during an evidence-based assessment of substance use disorder. If you're still wondering why this is important, it's really, really imperative for our clinical decisions to be accurate, right? So throughout the stages from kind of identification to treatment, even starting at prevention, we need to be able to adequately measure kind of these clinical outcomes or symptoms, for example, that are of interest in service of making the best clinical decisions. So whether that's related to triage, referral, the treatment approach that you use, follow-up, or so on. I'm primarily in a research role, so I often think about this a lot in terms of precision in our measurement. Are we actually measuring what we think we're measuring? And is our population of interest actually representative of somebody with a substance use disorder? I'm going to conclude with kind of a quick overview of my top recommendations. If you're really just here today to get the handy, how do I do this well? I will give you that at the end. And I'll also just kind of briefly touch on some of the future directions needed in this work. So first, let's just talk briefly about what a substance use disorder is. I could go on and on about this. This is kind of one of my areas of obsession and passion, is just trying to figure out what exactly is a substance use disorder. For time today, we're just going to talk about the DSM-5 criteria for substance use disorder. What I want to convey is that this is a kind of a narrow snapshot of what a substance use disorder is actually thought to be. So these criteria that I'll go over are by no means kind of the only manifestations of a substance use disorder or of symptoms for somebody who may have a substance use disorder. So the predominant diagnostic system that most of us use in the United States is a Diagnostic and Statistical Manual of Mental Disorders, which is currently in its 5th edition. And part of why we were invited to write this paper is because the DSM-5 recently underwent a text revision, but the substance use disorder diagnosis actually didn't change at all. So there were no significant changes made from the DSM-5 to the DSM-5 text revision for substance use disorders. So the way that a substance use disorder is described in the DSM-5 is by 11 specific criteria. I'll just run through them quickly in case you're not familiar. Using substances in larger amounts or over a longer period than initially intended. A desire or unsuccessful efforts to quit or cut down. Spending a significant amount of time trying to obtain, use, or recover from the effects of substance use. Experiencing a craving or a strong desire to use a substance, a failure to fulfill major responsibilities or obligations, continued use despite ongoing interpersonal or social problems, giving up important activities to use or because of use, recurrent use in situations where it's physically hazardous or dangerous, continued use despite physical or psychological problems that are thought to be exacerbated or caused by the substance use, tolerance, and then withdrawal. So for an individual to meet criteria for a diagnosis of substance use disorder, they need to meet 2 or more of these criteria in the past 12 months. The DSM incorporates kind of a severity grading that's thought to capture severity. And the idea here is that depending on the number of symptoms you endorse, that indicates how severe your substance use disorder is. So endorsing 2 to 3 criteria indicates a mild substance use disorder, 4 to 5 criteria indicates a moderate substance use disorder, and 6 or more indicates a severe substance use disorder. So one of the things that I also think is really important to understand beyond just the DSM-5 criteria is the etiology of substance use disorder. So what is thought to kind of cause, and also what is thought to maintain a substance use disorder over time. One model in the literature is the Alcohol and Addiction Research Domain Criteria, or the RDoC, and its corresponding assessment battery, which is known as the Addictions Neuroclinical Assessment, or ANA. The RDoC and ANA is really kind of the first addiction-specific framework that's focused on kind of these mechanisms or these processes that are thought to cause a substance use disorder. And this is the first framework to really synthesize research on the behavioral, neurobiological, and genetic features of substance use disorder and integrate them into this kind of higher order mechanistic framework, so to speak. And I'll walk you through that. Here in the image, if you look at these kind of pink boxes on the outside of the circle, you'll see that there's incentive salience, executive function, and what is labeled here as reward deficit, but also is sometimes represented by incentive salience. So the Addictions Neuroclinical Assessment kind of articulates these 3 broad domains as the most relevant to causing and maintaining a substance use disorder or addiction. This model is based on the Kuban-Leigh-Moll cycle of addiction, which is also displayed here kind of in the inner circle. And the idea with this theory is that addiction is kind of this acquired stage-like process that aligns with these specific neurobiological adaptations that occur within a person. So following kind of these initial pleasurable effects that people experience in this binge intoxication stage where the use is pleasurable, it's rewarding. This model puts forth that as somebody uses, they kind of proceed to this withdrawal or negative affect stage. So what happens here is that when short or long-term abstinence occurs, so someone stops using that substance either acutely or more long-term, that distress then results from that abstinence. And this is where the negative affect becomes really relevant. Sorry, my cat that is scratching. So once somebody enters this kind of withdrawal, negative affect stage, what happens and what is thought to happen according to this theory is that there then kind of becomes this preoccupation with alleviating that negative affect or with those withdrawal-related symptoms. What happens here is this preoccupation or anticipation of use. An individual is thought to experience this kind of intense need or craving for that substance, which then takes them back to the beginning of this cycle, results in them using again. And this cycle kind of proceeds in kind of a chronic way, in a continued way that kind of circles throughout, or spirals is sometimes how you'll hear it described. And this is interesting. Sometimes you'll hear this talked about in terms of, substances or chronic relapsing brain diseases, where the substance really kind of hijacks the reward pathways of the brain. And while that might be true for some individuals, there's research to suggest that this actually isn't true of every person with a substance use disorder or with addiction. Compulsive use is thought to be kind of one of the core components of addiction, and that's what this model really aims to articulate. But this overlooks actually many, many, many other etiologic theories that are in the literature. This is a pretty narrow representation of what we think is actually going on. So some of my work has focused on kind of answering that question. What other etiologic theories might that previous framework that I just showed you be overlooking or missing that are relevant to addiction and helping us understand a person's profile, kind of what is driving their substance use? So another way to conceptualize etiology is this framework here depicted, which is called the etiologic theory-based ontogenetic hierarchical framework of alcohol use disorder, or for short, the etoh framework. This was actually part of my dissertation work, so I don't have time, obviously, to go into all the details today, but I want to give kind of a broad overview of what you're looking at and why it might kind of add to or extend upon the ANA model. So as I mentioned, there are dozens of etiologic theories beyond that addiction cycle that I just showed you, many of which have pretty good empirical support, robust empirical support in the literature. Part of what I think has happened is, those theories perhaps apply to a subset of people with substance use disorders, and so they've kind of been overlooked as having relevance, whereas the brain disease model, which we just looked at, similar ideas that it might only kind of apply to a very severe type of person with a substance use disorder, but we've seen funding priorities kind of support these neurobiological explanations and kind of funding that type of work. So my theory here is that, these other theories that have been less commonly described are not necessarily because they lack merit, but maybe because some of the structural factors that have kind of impacted which theories have been elevated and researched and celebrated over time. So what I've done here is I identified the theories that have the most evidence in the literature for causing or maintaining substance use disorders. So integrating across all of these models, I developed this framework that similarly organizes the mechanisms in kind of a hierarchy, such that they're still organized by three broad domains. So we have reward, cognitive control, and negative valence and emotionality. And within each of these broader domains, there are more specific, kind of finer grained mechanisms that are encompassed by those broader domains. So these are kind of thought to be the three top types of processes that drive substance use disorders or maintain them over time. So the reward domain describes those processes that are implicated in the transformation of what are typically neutral stimuli or events or cues, is how they might be described, into these kind of more attractive or wanted stimuli. So we can think about the shift from natural reinforcers being very rewarding, but as somebody uses a substance over time, those natural reinforcers becoming less valued when compared to the substance. So within this domain, we see things like positive expectancies about use, reward sensitivity, incentive salience, for example. The cognitive control domain includes those mechanisms that are related to executive functioning, or kind of this idea of organizing behavior towards future goals or planning. My cat really wants to make this hard today. And the cognitive control related mechanisms include things like compulsive use, which really is captured by that addiction cycle I just showed you. So that's of course still relevant, but as you can see, maybe contextualized within a lot of other mechanisms as well. Things like conscientiousness, lack of conscientiousness being particularly risky, and difficulties with response inhibition. And then the negative valence and emotionality domain, while it does somewhat correspond to what I talked about earlier with this idea that with abstinence, there's negative affect, it's also a bit broader than that, in that it also includes things like punishment sensitivity or coping, trait negative emotionality beyond just kind of withdrawal specific negative emotionality. So this framework is much broader than that model I just showed you on the previous slide. And this can help us think about, one, what might those diagnostic criteria be missing for a person that might actually be relevant to their use or to their substance use disorder? And thinking about the ways that our current assessment approaches or our current standards might be limited in fully capturing this whole picture, and therefore limiting us in our ability to adequately characterize a person's substance use disorder. So one of the things that's not represented here that I think is really important to highlight is a lot of the modern conceptualizations of substance use disorder etiology really fail to talk about social and environmental factors. So things like family functioning, social connectedness, quality of life, meaning, racism-related stress, that are also relevant to etiology. One of the difficulties here, and one of the reasons why I think that hasn't been as consistently integrated, is because it's a little bit unclear whether these social and environmental factors are truly mechanisms or whether they might be kind of better described as moderators of the association between a true risk factor or mechanism for substance use disorder and, the mechanism and the substance use disorder. So what I mean by that is that social and environmental factors may actually make someone more vulnerable to developing or maintaining a substance use disorder, but might not be the core process driving their substance use disorder. So still, I really want to highlight that even though it's not depicted here, that it's really, really vital to consider and to assess those social and environmental factors when thinking about truly evidence-based assessment of substance use disorders. Okay, so I'll just kind of quickly go through a little bit about developmental course before I dive into the assessment component of this. But what we know about substance use disorders is that there's considerable variability across people, across groups of people based on characteristics like age or racial and ethnic identity. What I want to highlight here is that we do know that substance use disorders tend to peak between 18 and 22, 18 and 25, somewhere in there. You can see that just depicted on the left-hand side here with this blue bar. The rates of past year substance use disorder are much higher for this 18 to 25 group compared to the other age groups. And then when thinking about what types of substances people are kind of meeting criteria for, which type of substance use disorder, we see alcohol use disorder as really driving a lot of that prevalence rate. But then when you break it down a little bit more, you can see that cannabis becomes really relevant, opioids, methamphetamine, cocaine, and so on, kind of down the line here. What's important to highlight here is that most people don't just use one substance, but that doesn't necessarily mean that they have multiple substance use disorders. You can be a polysubstance user and not necessarily meet criteria for each of those substances. So this can be really important to think about in an assessment. Just because somebody meets criteria for an alcohol use disorder doesn't mean you should just assume they're not using other substances. You should still assess for that and gauge the extent to which it may be causing them problems or may not be causing them problems. There are thought to be various different trajectories, developmental trajectories of substance use, and I don't have a ton of time to go into today, but are covered a little bit more thoroughly in our paper. But the idea is that people's kind of trajectories across development or across the age ranges really vary. Some people, are high users across all developmental periods. Some people are adolescent limited, meaning that they drink a lot or use substances a lot in their adolescent years, but then kind of mature out later. There are people who are kind of steady increasers over time. So really, there's a lot of heterogeneity here, and people with substance use disorders are not all the same. As I mentioned, there's a ton of research on things like what puts people at risk for substance use disorders, what are the factors that might protect people against substance use disorders, and what are the pathways to desistance or to no longer meeting criteria for a substance use disorder. I want to highlight some of these that weren't already in that framework I showed you. Some of the primary risk factors for meeting criteria for a substance use disorder are early onset of first use, particularly for alcohol before the age of 15 or younger, tends to put people at a very increased risk for meeting criteria for an alcohol use disorder later in life. Associating with peers who use substances or family history of substance use or substance use disorders. There's really important differences within racial and ethnic groups here that I think are important to highlight. And sometimes you'll hear this referred to as the crossover effect, where people with minoritized racial and ethnic identities will have lower rates of substance use until a certain age or developmental stage, if you will. But then there will kind of be a crossover where they're not necessarily using more. There's no change necessarily in their use, but they all of a sudden kind of become at a higher risk for a substance use disorder. So it's important to think about what some of the kind of the structural systemic factors might be that cause this kind of crossover effect to occur. And that's something that we explore a little bit more in the paper. But thinking about, what are some of the limitations of the diagnostic criteria and who might be likely to be misdiagnosed or overdiagnosed as a result of kind of how those criteria are written, and who wrote the criteria to begin with. Some protective factors, positive parental influence, parental monitoring, social supports, positive bonds to community, school, being involved in like community events or service, and then pathways to desistance, maturing out, increased role responsibilities. Sometimes what we see represented in those trajectories are that people's use, they're not necessarily attempting to change their use, but it becomes kind of incompatible with their responsibilities or with the roles that they're taking on as they reach later developmental stages, such that their use kind of naturally decreases. And most people will recover from a substance use disorder without formal treatment. So quickly touching on some comorbidities here. Substance use disorders are highly comorbid with other forms of psychopathology, including externalizing disorders, internalizing disorders, personality, psychopathology. I would say that this co-occurrence of multiple diagnoses is really more of the rule than the exception. And there might be various reasons for this, right? And I don't intend to get into that today necessarily, but what I want to highlight is that if we're thinking about substance use disorders and kind of more of this dimensional framework, such as there's, various processes that kind of drive a substance use disorder for a given person, that the co-occurrence of a substance use disorder with another diagnosis might be driven by things like shared etiology. For example, if someone's experiencing a substance use disorder as well as depression or anxiety, perhaps there's really a negative affect component that's driving the co-occurrence of those two diagnoses. And that's important. When thinking about assessment, right, can we assess that in a more fine-grained way to figure out exactly how negative affect is relevant to both of these diagnoses, but also in terms of choosing treatment targets, right? If that's kind of the primary process that's driving somebody's substance use as well as their anxiety or their depression, can we target kind of that shared etiologic mechanism in our treatment approaches to be the most effective in reducing that person's symptoms? It's also key to attempt to the extent possible that it's, feasible or supported by time and resources in the organization to try to kind of parse the sources of this comorbidity, or at least better understand the comorbidity for a given person. Is it that there's a shared process driving these things? Is it that somebody is really only experiencing anxiety when they're using alcohol, and that's why they kind of got assigned those two diagnoses? It's pretty important as the clinician to come in, or the assessor, even in a research setting, to come in and try to understand exactly what the profile of functioning is and what the profile of symptoms is, particularly in cases where there is comorbidity or co-occurrence of diagnoses. Okay, so now that there's a little bit of background on what substance use disorders are, kind of what's important to think about when attempting to assess them, I want to jump into these three components that I previously mentioned that kind of work together to form this process of evidence-based assessment. So these, just to remind you, are the selection of assessment targets, the selection of assessment instruments to get at those targets, and then the specific assessment processes that someone engages in. So assessment targets is really the most important starting place, in my opinion. The identification of the substance use disorder related assessment target is going to guide kind of the rest of the process for you, the rest of the evidence-based assessment process. So you need to be able to answer as kind of a first step, what is the goal of the assessment? Is it to include or exclude people from a study? Is it to identify whether or not somebody has a substance use disorder? Is it more to understand that person's unique profile of symptoms? Is it to triage them or facilitate referral, help with case conceptualization, treatment planning, monitor treatment response? There could be many, many, many reasons why we're thinking about undertaking an assessment or why an assessment is indicated for a given person. Clarifying the assessment goal is really the first step here, is asking yourself, one, what is my goal? But also asking yourself, what is the patient's goal or the person I'm assessing's goal? Do they have an idea about what they're wanting to gain from that assessment. What do they hope to achieve as a result of that assessment? Do they want to improve their psychosocial functioning? Do they want to reduce or eliminate their substance use? Are they there because they're being required to go through an assessment for their job? What is their goal? Working alongside the individual in this way and kind of having this collaborative relationship is going to impact the assessment process from the beginning to the end. I think being able to convey to people with substance use disorders particularly, or who might be at risk for meeting criteria for a substance use disorder due to consequences or maybe ending up in an emergency department following and substance-related accident, for example, being able to really understand what they're hoping to get out of that and seeing if you can collaborate with them in choosing the target that feels most relevant for them, while also still meeting the goals that you might have or the requirements that you might be kind of restricted under based on your role or based on the setting in which you're in. So for example, in a primary care setting, the immediate goal might just be kind of the assessment of risky patterns of consumption or substance-related harm to determine if there is a need for treatment referral or for talking about other treatment options. If that person comes into your office and isn't necessarily, presenting saying, I'm here to talk about my substance use, I want treatment referrals, to come in and then say, I really want to assess you for a substance use disorder might be a little bit abrupt and might not be great for rapport with the individual. So having a conversation and being able to say, here's what I think might be important for us to assess and what I might be needing to assess based on the goals of this interaction or this encounter. What are you here to do today? What are you hoping to achieve? And seeing if you can really kind of support the individual's autonomy in that while still getting the information that you feel like is important to assess. So the collaboration on selecting a treatment target is oftentimes skipped over or kind of sped past, or we're kind of just given these organization-based protocols and told this is what you do every time somebody comes in and, crosses over this screening threshold on this instrument, when really, in my opinion, it needs to be a much more involved process. So the next step here, the next component of an evidence-based assessment is selecting the appropriate assessment instrument based on the assessment targets of interest. As I mentioned at the beginning, psychometric properties are important, but not always kind of the whole picture. So what I'm going to show you next are some instruments that we recommend based on having kind of adequate psychometric properties. But what's really important to understand here is that psychometric information or psychometric properties are not kind of inherent properties or information of a measure. It's not the measure that has psychometric validity or reliability. It's how that measure was administered in a particular condition or setting and to whom it was administered. So psychometric properties are not properties of the measure, but they're context dependent. So it's really important to think about, valid and reliable for whom, in what settings, under what conditions. Oftentimes there's validation work done on a measure. It might be kind of validated in one very specific population, and then we kind of go out and we apply it to everybody, expecting it to perform the same across every setting or population or age. And that's just simply not the case. We cannot just assume that a measure has reliability and validity across all populations if it was only validated in one specific group. So of course, we want to be thinking about things like reliability of the measure. Does it produce similar results under consistent conditions? The validity, which is the measure assessing what we think it's measuring. Is it actually giving us accurate information about the construct we're interested in? And also the clinical utility, which is, does this assessment approach actually improve outcomes, efficiency? Does it help us improve the accuracy of our assessment? So these are kind of things that we need to consider holistically and specific to kind of the particular patient we're working with or the particular population that we're working with when selecting the instrument. There are three different categories that I divide substance use disorder assessments up into. These are by no means kind of discrete categories, and there's sometimes overlap across these, but typically we see assessment instruments divided into screening instruments, diagnostic instruments, and then outcome or treatment monitoring. And I'll go into a little bit of detail on what I mean by outcome or treatment monitoring, but here are some of the examples of what that means. One of the important things in this literature, I think, is that it's key to think about, because there are developmental differences and there's kind of different developmental trajectories, we don't necessarily want to broadly apply all screening or all diagnostic tools across developmental groups. And so what I've done in this paper is broken it out into adolescent and then adult recommendations. So the instruments that we suggest in this manuscript were reviewed for their psychometric properties. And we also kind of made comments about where there might not be psychometric information. For example, Kamala Venner does a lot of work with American Indians and Alaskan Natives, and there's just not a lot of validated instruments for these populations for substance use disorders. So what we really try to do in the paper, and I would encourage you to look into it if you plan to use one of these instruments, particularly in a population that's, not white or highly educated, look at that paper and see, is there psychometric information to support the use of this instrument in the population that I'm serving or in the specific patient I'm working with. Don't just kind of assume that this tool will work for you because it's in this paper. So I'm not going to go through all of these because you can look them up in the paper. But I do want to highlight, kind of at least put up on the screen here and make available on these slides for you for later reference, what some of the tools are. The goal of screening, obviously, is kind of to balance this idea of efficiency with sensitivity. We want to be able to screen somebody relatively briefly while also being sure that we're catching people who are at risk or who have a substance use disorder, or who are likely to have a substance use disorder. So many of these tools take 5 to 10 minutes maximum. And in the tables that we have in the manuscript, we actually have a column that kind of says how long each instrument takes to administer. So these are typically fairly brief and will usually give you an idea of whether somebody's consumption or is kind of over the recommended limits and puts them at risk, or whether they're experiencing consequences as a result of their use, which tends to align with the diagnostic criteria and increases the likelihood that they would meet criteria for a substance use disorder. So I highlight this as a categorical diagnosis, a set of categorical diagnostic instruments, because most of what these instruments do is they will be able to tell you, does this person have substance use disorder or do they not, based on typically DSM criteria. That's useful information, but it's necessarily limited, and that it's not telling you a whole lot about the person's profile. It's really just giving you a categorical yes or no, this person meets criteria or they do not. So while I recommend these instruments and think they're great, they're well validated, they're reliable, they're commonly used and supported by federal agencies, they're limited in that they don't necessarily capture the full picture all of the time. They're going to capture those DSM-5 criteria, but as I've mentioned up to this point, those criteria don't capture everything that might be relevant to a person's profile. It doesn't capture information about well-being or functioning. So this is a useful starting place and may be kind of what you're able to do within the confines of time and resources. But I also really want to advocate for combining these categorical diagnostic interviews or approaches with other instruments or other assessments that can help kind of provide additional information about that person. So one of the examples I like to highlight here is that substance use disorder criteria are really thought to kind of count equally toward the diagnosis, meaning that you can endorse any of the 11 criteria and they all count equally towards you having a substance use disorder or not having a substance use disorder. But this assumption actually doesn't hold up empirically, and individual symptoms can provide additional information that's not offered by the overall diagnosis. So what I mean by that is that somebody who meets criteria for a substance use disorder based on, spending a lot of time using or failure to fill major role responsibilities, for example, is probably qualitatively different from somebody who's experiencing alcohol-related withdrawal, for example, or persistent craving. Those are kind of different ends of the substance use disorder continuum, I would argue. And the empirical data does support that. So if you're really just saying, this person meets criteria or doesn't meet criteria, you might be missing kind of that important information about truly what is going on for this person, what is driving their substance use disorder, what's causing them to meet criteria for a substance use disorder. So if we can really, even if you have to operate within this categorical diagnostic framework and you're not able to add an additional assessment instruments, just taking a little bit of time to consider, what exact symptoms are they meeting? And what kind of might be kind of the antecedents of them kind of experiencing that symptom or that consequence in their life, trying to gain a holistic understanding through thinking more at kind of the symptom level rather than the overall diagnosis level. And then, as I mentioned, what can be really vital here are including additional instruments that I've called these outcome and treatment monitoring, but these are just kind of relevant correlates for substance use disorder. That's more of what these represent. So the DSM-5 criteria actually don't tell us a lot about someone's consumption oftentimes. So that's by design, because consumption isn't necessarily pathological in itself, but it can actually provide a lot of helpful information in terms of kind of tracking somebody's response over time or getting a better understanding of what their pattern of use is like that is driving them to causing them to meet criteria for a substance use disorder. Craving is thought to be one of the main drivers of relapse, for example. If somebody is experiencing elevated craving in one of your sessions after maybe a large reduction in their use, that's clinically relevant information, right? They're experiencing elevated craving. How can we address that in our sessions? Even if you're not kind of the treating clinician, I'm a psychologist, so I'm talking about this as if I'm in a treatment setting, that can be relevant information for choosing a medication, right? This is all information that's not necessarily captured always by a categorical diagnosis that can be really relevant to informing decisions that we make as professionals. So the other domains that I highlight here are withdrawal, which may be particularly relevant in some settings like the emergency department. But what I really want to spend time talking about is functioning and well-being, a domain that's really oftentimes overlooked and can be a really nice way to kind of bring in strengths for people when talking about substance use disorders, particularly people who are not necessarily presenting for a problem related to substance use or who are not kind of saying, I'm here to reduce my use, is really trying to understand what's important to this person. How are they functioning in their day-to-day life? How is their well-being? Can we kind of agree, that perhaps as the provider, I want to track their use over time, but maybe they're coming in and presenting and saying, my relationship with my wife or my partner has been really a challenge for me. And that's really what I'm concerned about. They told me that if I don't come and talk to you about this, we're going to need to separate, for example. In your head as the provider, you might be thinking, well, it sounds like your use is maybe driving some of these problems that you're having, but that individual is not endorsing their use as a problem. Being able to say in that kind of first step of deciding on the assessment targets and the subsequent decisions after that, I'm hearing you say that you're having difficulties with your partner. Would it be okay if we took a look at some of the things that might be going on here, like your relationship quality, your consumption, trying to more holistically approach this problem rather than kind of coming in as this kind of authority, this expert saying, I really think your use is driving the problem. So we're going to talk about that. We're going to assess that. Really trying to hear the individual and also recognize that substance use disorders don't exist in a vacuum. There are many different things that might cause or maintain that for people, and being able to listen and identify those targets and select the appropriate tool to assess them or to even track them over time is really key. It can support the patient's autonomy and actually improve the utility of the assessment itself if the person feels like they're getting meaningful feedback or information from it. Okay. And then another component of evidence-based assessment that I hear overlooked a lot is this idea of assessment processes. So as I've kind of talked about, this evidence-based assessment is really a decision-making task, right? As an assessor, we're kind of required to take this iterative approach to formulating and testing hypotheses. And as we integrate more data about a person or more information, we can kind of test whether those hypotheses are true or not. We can identify places where we might need more data to best formulate kind of a picture of what's going on. So what I view as particularly important assessment processes in the context of a truly evidence-based assessment of substance use disorder are both relational processes and also technical processes. So when I say relational processes, what I mean here is that the assessment process is not meant to kind of be this cold, I'm just here to get the information, to ask you the questions, to like develop my hypotheses and move on. It's really not what an evidence-based assessment is supposed to look like. So what we're kind of required to do, in that this is a process where we're interacting with people, is we really first, before even engaging in an assessment, is need to take a time to self-reflect on our biases, on our beliefs about people who use substances and what that means about them. I think oftentimes we have these preconceived notions or these assumptions or stereotypes about what a person with a substance use disorder looks like or what their life is like because they use substances. And we need to be able to be aware of those things as we're kind of engaging in this process, throughout the process, not just a one-time thing, kind of something that we should be reflecting on as a relational component of evidence-based assessment throughout. What I find really important about this is that people who use substances have often been highly stigmatized. They might have a hard time trusting the provider to even provide you information. So being sure that you're kind of taking the time to, one, self-reflect, and two, then be able to successfully build rapport with that person can really impact the information that you gather and what kind of comes with what you do with that information after the assessment. So here's where I really suggest, embracing what a lot of us have been trained in, a motivational interviewing style, or at least really engaging with that person with the goal of understanding and empowering them, rather than just trying to get information from them or kind of get them on to the next step. Embracing a spirit of compassion and understanding rather than one of judgment or, I'm just here to get information from you so I can kind of move on to the next one can really go a long way in assessments, and particularly in assessments with people who use substances. And then the other relational aspect is just demonstrating flexibility, particularly depending on the setting you're in. For example, when I've been in like emergency departments or inpatient settings where someone's at high risk of withdrawal or isn't currently in withdrawal, it's probably not the time to dive into your evidence-based assessment. So demonstrating flexibility in how you're doing, kind of how you're approaching an assessment and how you're engaging in kind of the different steps of the assessment can go a long way. And then just to quickly go over some technical processes that are key here, can be really important to assess within specific drug classes. So there might be unique patterns of use for each different substance that a person uses, as well as different antecedents and consequences associated with that use. As I mentioned at the beginning, thinking about comorbidity and attempting to assess that if you have the flexibility to do so. Considering how one's identities are influential throughout the whole assessment process and throughout the eventual conceptualization that you'll come to. I often see this overlooked. We get kind of so married to our diagnostic criteria that we forget there's a person sitting in front of us. So if we can really, again, holistically think about the individual in front of us, what might be their cultural understandings of their symptoms? What might be the treatments that they see as most important or endorse most strongly or believe would be the most helpful? Really kind of inquiring about these processes, either formally or informally, to understand how their symptoms are viewed within their community. what degree of social support they have, how their use is or isn't impacting their functioning, and so on. This is also related, obviously, to social determinants that might be at play here for a given person. Really, it can be really important to understand, again, just beyond somebody's use or the consequences they're experiencing, what is their housing situation right now? Do they have access to healthcare? What is their income like? Are they experiencing discrimination on a daily basis? It's really trying to understand beyond the psychosocial consequences, what might be at play for the person here. And then informant reports. This might be relevant kind of depending on the population or the setting you're in, but really, if informant reports come into play, thinking about how to really integrate all available information in the course of an evidence-based assessment, but still be aware of discrepancies that might arise and highlighting those and trying to frame them kind of in service of positive treatment outcomes rather than defaulting to like a stigmatizing perspective of, this person must be lying to me because there's discrepant informant reports, for example. Okay, so just a quick overview of recommendations and kind of take home here in the course of an evidence-based assessment for a substance use disorder. Reflect on your biases, beliefs, and values, including how they relate to people that use substances or have a substance use disorder. View the patient as a whole person, considering their profile of symptoms, their functioning, inclusive of things like strengths, comorbidities, social and cultural determinants. Collaborate with the patient or the person you're assessing, or maybe even their family or other providers to select the assessment target that best fits their goals. Also, while understanding and balancing that some targets might be required by the specific clinician or organization, for example. And this will then guide the selection of the best instruments for that target. And you can select the best instrument based on whether the psychometric properties support that instrument's use for that given person. And again, here thinking about how you can really incorporate dimensional approaches over purely categorical SUD, no SUD approaches, and then encourage direct assessment of things like functioning, well-being, and strengths. And then finally, assessment information and data should be integrated in a comprehensive, holistic manner, considering things like informant reports, collateral information, and explicitly noting any limitations of the conclusions that you come to. For example, if you had to use an assessment instrument that was not sufficiently validated in the population of interest or in a population that was sufficiently similar to the individual you assessed, providing that information transparently. Here are references. The paper that I've been referencing today is this top one. And if you follow this DOI link, it will take you to an open access version of the paper. And with that, I want to thank my collaborators and also NIAAA for supporting this work. Thank you.
Thank you, Dr. Bonas. Great presentation. Obviously a topic near and dear to my heart and the rest of us who are with the ASAP team, but I just bringing up some really important points. I think we have probably like 5 minutes for some questions. If anybody has questions, obviously you're free to leave if you need to do that, but either raise your hand or feel free to just unmute. Can't see everybody, so if you have your hand raised and I'm not calling on you, just unmute. Lily's putting the link for the feedback form in the chat, so if you would please do that as well. Dr. Bonas, one of the, Kathy, please go ahead.
Yeah, I just have one question. Thank you for a great talk, first of all. What I wondered is that you talked a lot about the executive dysfunction in many of people who are substance abusers or users. And I didn't hear you say anything about neuropsychological evaluation to characterize those problems. And I was wondering how that worked.
Yeah, I think that's important. That's an important component. I think much of the instruments actually that I described do include components that would be related to executive functioning, things like impulsivity or response inhibition or difficulty kind of in, stopping actions, for example. But in neuropsych, if that's implicated and there's reason to suspect, for example, I've worked with many people that have kind of co-occurring traumatic brain injuries and substance use disorders, or kind of histories of traumatic brain injury of some sort or head injury. That would be someone that I would absolutely refer for a comprehensive neuropsych. I think we need to be careful about saying that every person we're assessing for a substance use disorder needs a full neuropsych assessment, just for accessibility purposes. But that's absolutely an important component, and one that I think a lot about, particularly within that cognitive control and executive functioning domain.
Right. Right. And I was just wondering if you, it seems to me like it would be useful to at least have a screening measure for some of those that aren't based on subjective response, but are actually based on a performance-based evaluation.
Yeah, so I should highlight that most of what I talked about today are self-report instruments, just mostly for efficiency and feasibility in many settings. But that's absolutely an important consideration. The ANA battery that I talked about at the beginning that comes out of NIAAA, in their battery for the cognitive control and executive functioning, they do include more behavioral tasks and things that we might see in a neuropsych battery for that exact reason that you're mentioning. So yeah, it's definitely something that people are thinking about. That's actually been one of the harder domains to measure with self-report. And I think that's largely why, is we just don't have great self-report assessments of that domain. Yeah. Really great point. Mm-hmm.
The one question I had is, I have always valued the Hughes quality of life scale, but is there an adolescent version of that, or is there? Do you have recommendations with regard to quality of life, particularly with transitional age individuals?
Yeah, actually, I think the addiction severity index is recommended for, I haven't personally used that one. That was one that was a little bit new to me, but they have a teen addiction severity index, a TSI, and I think that they kind of use that transitionally to start thinking about what are some of the functioning and well-being things that might be relevant for adults that are not so relevant for adolescents or even young adults. So that would be my idea of where to start with that. I'm primarily an adult person, so my co-authors really helped me with the adolescent piece of that, but that might be my hunch of where to look.
I'll ask JC too.
JC would know.
Yeah. Okay, great. Thank you. Any other questions before we end today? All right, Dr. Bonis, thank you so much for spending your Friday afternoon with us. And thanks to all of you for coming. Please fill out the evaluation form, if you will, as well as making sure you get the QR code or do the link so that you can get credit for having been here. All right. Bye, all.
Thanks for having me.